Very good morning to all of you. I'm Dr. K. Himabindu, working as professor in the Department of Pharmacology at Andhra Medical College and Dr. NTR University of Health Sciences from India. Today's my topic of presentation is a critical analysis of recent breakthroughs in breast cancer treatment and revolutionizing oncology and renewing hope. So coming to the background of the breast cancer, an introduction. The breast cancer is the most common malignancy among women worldwide. It accounts for 1 in 4 cancer diagnoses in women. As per Global Cancer Observatory, 2.3 million new cases were reported, whereas 685,000 deaths were reported globally, which are mainly due to limited healthcare access. And the traditional or conventional modality of management of breast cancer was early surgery followed by radiation. The early surgery included radical mastectomy with the removal of breast tissue, chest muscles, and lymph nodes, which has shown improved local control, but there are the cons that are disfigurement and trauma. And the radiation therapy, which was used after the surgery to eliminate the residual disease, if any. And there were 1960s breakthroughs, which have emanated with the breast conservating surgery after the radical mastectomy, along with radiation, which have improved the survival rates comparable to single radical mastectomy without radiation. Then came in 1970s systemic chemotherapy, which included CMF regimen, that is cyclophosphamide, methotrexate, and fluorouracil, with improved survival rate. And later on, anthracyclines and taxanes were also used in the management of breast cancer. Then came hormonal therapies like tamoxifen for hormone receptor positive cases and aromatase inhibitors like letrozole and anastrozole for postmenopausal women. But there are certain limitations of conventional treatments like non-specific cytotoxicity like cardiotoxicity, myelosuppression, and neuropathy, etc. And there was a risk of tumor heterogeneity, that is like different kinds of tumors present in the same breast tissue, which have led to the resistance and recurrence. So there was a need for molecular targeted approaches to improve precision and minimize harm. So then came molecular and genetic understanding of breast cancer, which have revealed that breast cancer genes 1 and 2 mutations discovered in 1990s with mutations impairing the gene DNA repair via homologous recombination. So here the carriers face risk of more than 65% lifetime risk. So the genetic testing enabled the early detection, prophylactic strategies, and targeted therapy with PARP inhibitors. And then there are varieties of molecular subtypes also in the breast cancer, which were like HER2 positive, which we are all well aware of, with the ERBB2 gene amplification. So it is a kind of an aggressive tumor. And then luminal A and B cancers, molecular subtype, which is hormone receptor positive, which easily responds to endocrine therapy, but it is differing in proliferation and outcomes. Then comes the triple negative breast cancer with poor prognosis because of lacking estrogen, progesterone, and HER2 receptors with limited treatment options. So it is resistant to the conventional modalities of management and HER2 targeted therapies as well, because it lacks estrogen, progesterone, and HER2 receptors. So the evolution of treatment, if we look back, the traditional treatments like surgery, chemotherapy, and radiotherapy, they were there as traditional management with the challenges of molecular heterogeneity and treatment resistance. And then modern advances have come on with shift to personalized and targeted therapies based on molecular biology, genetic profiling, and immunology as well. But the outcomes with these modern advances are improved survival rate and enhanced quality of life. So what is the rationale of the study, that why we have taken up the study? The study motivation was the recent breakthroughs which we have seen in breast cancer treatment and the aggressive type of cancers which are more common in the society, like triple negative breast cancer. And the innovative therapies like targeted agents, we have seen that CDK4 or 6 inhibitors and PRP inhibitors and immune checkpoint inhibitors. And we have searched for the literature with emerging technologies in the modalities of treatment for breast cancer, innovative therapies, especially like nanotechnology, gene editing, and precision medicine. But the challenges and gaps were disparities in access, affordability, and long-term efficacy, which we have searched out thoroughly. So there was the study aim was the bridging the gap between innovation and implementation, exploring how scientific advances are transforming oncology and renewing hope. The scope of the study was we have selectively taken the literature from 2015 to 2025, focusing the areas like main innovative therapies, that is targeted therapy, immunotherapy, genetic and molecular innovations, nanotechnology, and personal medicine, emphasizing specifically on clinical relevance, accessibility, and transformative potential in oncology. But the limitations in our study were secondary data reliance with variability in reporting standards and outcomes, and recent innovations with limited long-term survival and safety data, which need to be studied further. And then there was a global disparity in the healthcare infrastructure when compared with the developing and developed countries, with differences in the approachability. Then coming to the research methodology, which we have gone ahead was, there was qualitative and analytical design with secondary data analysis, which synthesized the empirical findings, clinical trials, and scholarly interpretations. The purpose of the design was exploring the complex therapeutic developments, interpreting the trends and transformative impacts in oncology, and emphasizing understanding over quantification. The analytical focus was mainly integrating the medical, ethical, and socioeconomic, not just medical, comparing the efficacy and the innovation and accessibility of all the innovative modalities of treatment, as well as technologies like targeted therapies, immunotherapies, gene editing, nanomedicine, and precision oncology. And the data sources which we have used were from the existing literature with evidence-based conclusions. The sources for mainly peer-reviewed journals like Lancet Oncology, Nature Reviews Cancer, JAMA Oncology, New England Journal of Medicine, and Cancer Journal for Clinicians, and which were selected for high impact and relevance in oncology research. Then, along with that, international and statistical databases like the World Health Organization and National Cancer Institute, and International Agency for Research on Cancer, which provided the global or regional data on incidence, mortality, and survival. And we also included the clinical trials and meta-analysis like PubMed, Cochrane database of systematic reviews, and large-scale trials and systematic reviews as well. The analysis was done with triangulation of credibility, depth of analysis, and cross-verification of trends. And coming to the inclusion and exclusion criteria, the publications which were between 2015 and 25 were taken as inclusion criteria, with peer-reviewed articles, systematic reviews, and meta-analysis and clinical trial reports, whereas conference papers, unpublished theses, and editorials were excluded from the study. And subject focus, as we already discussed, the innovative modalities of treatment and techniques were focused particularly. And the English language published articles were only taken up, and the data authenticity was from reportable institutions, medical bodies, and government agencies. And we have seen the outcome that a credible, contemporary, and scientifically rigorous foundation for analysis is being done. So thematic analysis approach was done with three different modality: clinical efficacy, accessibility for all kinds of public, and also innovation when compared to the traditional approach. And apart from that, not the least one, but very important one, the ethical foundations were also taken care of with the secondary, even though it is the study research was solely depending upon secondary data. So we took care that it complied with the international research ethics and data protection norms. Then coming to the results and discussion, HER2 target agents, they improved overall survival rate by 18.5 months, whereas CDK4 or 6 inhibitors improved progression-free survival rate by 9.3 months in hormone receptor positive cases. And we have seen this with the trial evidence of Cleopatra and Destiny Brush 3 trial, where we could see the HER2 dual blockade, that is with the HER2 receptor blockade with the double drugs, which reduce the relapse of the cases with lowered mortality by 30% when compared to the traditional therapy. And there was a marked shift towards precision oncology. But the challenges with this group of agents were resistance mechanisms with HER2 mutations and high cost and limited infrastructure in low-income regions. So we can have the future direction of integrating molecular diagnostics and AI-driven predictive models, which can enable personalized optimized therapy with HER2 targeted agents. Then coming to the other innovative therapy, that is immunotherapy, which has transformative potential, especially in triple-negative breast cancer, which we cannot treat with any other group of drugs. And checkpoint inhibitors were used here via PD-1 or PD-L1 blockade. And Keynote 355 trial has demonstrated with a response rate of 54% with a combination of pembrolizumab and chemotherapy with 4.41 months median overall survival rate in triple negative breast cancer, suggesting durable responses in refractory cases, and synergistic strategies like a combination therapy can be very useful in these cases, like immunotherapy plus targeted agents. So the challenges here are immune-related adverse events like colitis, hepatitis, pneumonitis, and endocrinopathies, and then high cost, need for biomarker testing for every patient, and then limited feasibility in low resource settings. So the future directions in this area with this group of management could be, it offers renewed hope, no doubt, but the success depends on the managing toxicity, cost, and equity in access. So future directions can be focused on this point particularly. Then coming to the gene and RNA-based therapies, CRISPR-Cas9 gene editing can be done with target mutations in BRCA1 and other genes as well, with durable, potentially curative tumor suppression, and RNA-based therapies like siRNA silence oncogenes with tumor inhibition, and mRNA vaccines using tumor-specific neoantigens with long-lasting immune responses. So it has shown, this group of therapies have shown mean overall survival gain of 14.7 months and response rate of 61%. But the challenges for ethical and regulatory concerns, because we are dealing with the gene modification of the patients, where it can lead to even irreversible genetic changes, and confidentiality of the patient data is also very important here. And off-target effects, biosecurity threats, unequal access are also other types of challenges that we could see. And there can be future directions for need for ethical governance and regulatory oversight. Then coming to the nanomedicine and precision oncology, nanocarriers like liposomes, polymeric nanoparticles, smart systems, they enable targeted drug delivery with improved bioavailability, minimizing the systemic toxicity of the drugs. Liposomal doxorubicin with the specific dosage formulations reduced cardiotoxicity with extended half-life. So dosage formulations can be modified to reduce the toxicity and improving the bioavailability of for the patients. And then stimuli responsive nanocarriers like they are triggered by pH temperature enzymes. They allow controlled localized drug release. And trial evidence has proved that the progression-free survival gain of 7.6 months is seen with this therapy, with adverse events only 10%, and high tolerability and precision also can be seen because of the modification of the dosage formulations. But the challenges could be some amount of safety, scalability, and affordability. So especially critical in developing economies in developing countries and underdeveloped countries especially. The future directions can be nanomedicine when combined with AI, that is artificial intelligence and precision oncology. Therapeutic innovation meets data-driven customization with integration of genomic, proteomic, and imaging data, designing individualized treatment protocols for every patient, for every type of the breast cancer that we can see in the society. So it predicts the tumor subtype progression and therapy response. So we can see the results that we have depicted, we have discussed already in the discussion part. So I'm depicting these results here in the tabular forms and figure forms. So this is the survival benefits across breast cancer treatment, same in figure form. Then patient response rate, same in figure form. And then accessibility versus adverse events by treatment type, same in figure form. And then finally, the relationship between treatment accessibility and survival gain. So this is how we got the results. Then coming to the socio-economic implications of the study, there were global disparities in outcomes when compared to the high socio-economic group and low and middle socio-economic group, with survival rates of more than 85% in high-income countries and less than 60% in low and middle income countries, with access gap ranging from 38 to 68% because of the restricted access to innovative drugs in the low and middle income countries. There were also economic barriers reported, and then patient restrictions and pricing monopolies and limited insurance coverage for the public. And then digital divide limits use of artificial intelligence diagnostic tools and genomic sequencing platforms, essential for personalized treatment. And then the ethical complications were gene editing risk, which we have already discussed with CRISPR technology for germline modification and irreversible genetic changes. And data privacy, because of unregulated use of genetic data for commercial gain, could be another ethical implication. So there are issues of consent, equity, and scientific responsibility. So with this long discussion, we conclude the session with a summary like precision-based evolution, that is like traditional treatment, like which includes surgery, chemotherapy, and radiation therapy, shifting to targeted personalized therapies with the goal of maximizing efficacy and minimizing toxicity. So how it goes through, targeted therapies have average overall survival gain 18.5 months with response rate of 72%. It is most effective current intervention. An immunotherapy, modest survival gain, long-lasting remission in previously incurable triple-negative breast cancers especially. And gene and RNA-based therapies shift from control to molecular correction with personalized mRNA vaccines and CRISPR editing show curative potential with safety, affordability, and long-term effects under review. And then regarding the tech-driven precision, nanomedicines like nano carriers reduced adverse events by up to 50%, and AI integration is helpful for early detection, recurrence prediction, and optimized treatment for every case of breast cancer. And the clinical impact was there was a quality of life gain could be seen. And then with the less toxicity, shorter hospital stays, improved psychosocial outcomes. So the trailer treatment could be combination of psychological relief and renewed hope for all the breast cancer patients. But the equity challenges revealed with an access gap of high income countries leading in absorption with the low and medium income countries facing infrastructure, regulatory, and economic barriers. And the possible solutions that we can think of in the future could be the development of cost-effective biosimilars and tele-oncology services with universal health coverage to each and every person in the society. Then coming to the future direction specifically, genomics decode tumor heterogeneity, resistance mechanism, and mutational landscapes using the advanced tools like single cell sequencing and spatial transcriptomics with the goal of discovering new drug targets and refined biomarker-driven treatments for every case of breast cancer. So we can integrate the machine learning into clinical workflows. So enable real-time monitoring of data privacy, algorithmic transparency, and systemic interoperability with the addressing challenges in ethics like gene editing, data sharing, and AI-assisted diagnostics, upholding the principles of ethical management, that is with beneficiency, autonomy, and justice, with holistic collaboration, that is like teamwork with involving the other groups of people also, not only just the scientists and doctors. We can involve molecular biologists, computer scientists, clinicians, bioethicists, policymakers, and sociologists as well, to ensure that the breast cancer care is scientifically sound, ethically responsible, and socially inclusive. So when we compare with the traditional monotherapies, then the evolved combination therapies, there were limitations with the monotherapies due to tumor heterogeneity and resistance. Whereas with combination therapies, most oftenly used, that is targeted therapies combined with immunotherapies, they enhance efficacy by disrupting oncogenic pathways, boosting immune responses. So case synergistic approaches that we can see here, HER2 inhibitors with PD-1 or PD-L1 checkpoint blockers, they had shown superior tumor regression, along with the prolonged progression-free survival. And BRP inhibitors, when combined with immune checkpoint inhibitors, they were effective in BRCA mutated and triple-negative breast cancer because of the DNA damage with the neoantigen formation, which is leading to the cytotoxic T cell activation. But here the challenges could be toxicity amplification, high treatment costs, and resource-limited settings. Future focus can be developing biomarker-guided combination protocols with the multimodal integration of all the innovative therapies. And the goal could be overcoming resistance, extending survival for every patient suffering from the breast cancer. Then global disparities were also found out with uneven impact of breakthroughs due to high drug costs, limited genomic testing infrastructure in certain developing countries, and patent monopolies. So low and medium income countries faced restricted access to precision therapies. So affordable solutions could be cost-effective biosimilars and generics, and lower cost, maintaining efficacy, decentralization of molecular diagnostic labs and tele-oncology platforms, expanding the genomic profiling and remote care even in the rural areas of developing countries. So the public-private partnership can be done with a collaboration among governments, research institutions, and pharma companies, accelerating the technology transfer and local production of cancer medicines. And also AI-powered health systems, which can predict patient needs, reduce diagnostic delays, and improve treatment adherence in under-resourced settings. So the policy and ethical frameworks finally were with the global oversight of organizations like World Health Organization and UNESCO International Bioethics Committee, which can stress ethical oversight in genetic interventions and AI-driven research. And the ethical governance must include informed consent from every patient, every data or patient, data transparency if we collect the data, and the accountability mechanisms. And the transparency tools like global biotechnology registries enable monitoring of gene editing, clinical trials, and AI algorithms, which promote shared accountability and scientific integrity. So the final insight in this research could be the future breast cancer care must balance innovation with ethical responsibility, ensuring breakthroughs to serve humanity. So the take-home message for this session is innovation must align with universal accessibility. It is not just bringing out the newer innovative therapies, but accessibility for every socioeconomic group in every country, whatever may be, whether it is developed or developing country. So it has to be accessible for every patient, whatever innovation that we are developing in the society. And we should ensure life-saving therapies reach all patients, regardless of geography or income. And future breast cancer care must balance innovation with ethical responsibility, which is a very, very important criteria, ensuring breakthroughs to serve the entire humanity. Thank you. Thank you, everyone. Thank you for giving me this wonderful opportunity to present my research in this broad international conference. Thank you for the team.
Good morning to everyone. My name is Emefide Nderejijen, and I'm a PhD candidate at University of the Philippines, and I'm currently now working in University of Jitwe. And today I'm going to present to you my research, which was entitled Breast Cancer Awareness and Screening Practice Among Women, a case study which was happening at Tamale metropolis in Ghana. Now moving to the background of the study. Globally, we have seen that breast cancer accounts approximately 2.4 million new cases and 9 million deaths annually, which is representing nearly 15% of all cancer-related deaths among women. And despite of this burden, about 60% of the new cases are projected to occur in developing countries where access to early detection and treatment have remained limited. Now moving to the Africa issue. In Africa, more than also 50% of women have never undergone a breast screen test, which lead also to late-stage diagnosis and poor survival outcome. And the continent recorded the highest age standard mortality rate from a breast cancer, with most cases detected only when the disease is advanced. Now moving where the study has been carried out there in Ghana, it has been shown that also breast cancer constitutes the most prevalent malignant among women, with around 70% of cases which are presenting at advanced age. And each year, approximately 2,900 new cases are being reported in Ghana, and at least 1 in 8 women have diagnosed die from the disease due to a delayed detection and also to recall limited access to a specialized care. Now moving to the gap of the study, or the purpose of us making this research is because there was a limited data on breast cancer awareness, perception, and also screening practice among women in the north region of Ghana, particularly in the region called Tamale metropolis. And the absence of the region-specific evidence have hindered the development of target intervention in order to promote early detection and also to improve outcome in those underserved community. And regarding now the research questions that have guided our study, The first research question was assess the level of awareness of breast cancer among adult women in Tamala metropolis. And the research question number 2 was examining the perception of adult women toward breast cancer screening in Tamala metropolis. And the third question was to assess whether the breast cancer screening practice among adult women in Tamala metropolis. And the fourth question was to determine whether there is a relationship now between the social demographic characteristics such as age, religion, education level, and ethnicity, and breast cancer awareness of women in Tamala metropolis. And the last one was also to determine whether there is also a relationship that occurs between breast cancer screening practice and also to equal social demographic characteristics of women who are located in Tamala metropolis. Now moving to the conceptual framework that has guided our study. In the independent variable, we was having social demographic variables such as age, religion, ethnicity, and education level. While on the other hand, the independent variable that was also having was breast cancer perception and attitude. While looking on the dependent variable that was having was also breast cancer awareness and screening. Now moving to the methodology that we have used while conducting this study. The research design was the study employed what we call a descriptive cross-sectional research design in order to collect and also to analyze the data at a single point in time. While looking on the data collection method that we use, they were collected by using what we call a self-structured questionnaire that was containing a close-ended and also dichotomous item that was assessed the social demographic characteristic and also breast cancer awareness and perception as we have seen in the research question. Now moving to the sampling technique that we use in this study, we use a stratified random sampling technique with a proportional allocation across area council that was used to select 396 adult women who were aged 18 years and above from those locations called Tamala metropolis. Now moving to the statistical analysis that we have been used in order to statistically analyze those data that we have collected. We use descriptive statistic and also inferential tests such as Pearson t-test, query test, and also what we call Fisher exact test to determine whether there is association between those variables, as we have already stated in the research questions that we have, those questions that ask whether there is a significant relationship between. And now moving to the result and discussion. On the first research question, which we was having that asked whether we have respondent level awareness of breast cancer, we was able to see that there is an average. And this average is the average of awareness, where the findings have revealed that the respondent have an average level of awareness regarding breast cancer risk factor, which also indicate a moderate understanding with a notable knowledge gap. Now moving again to the questionnaire item that got higher degree, it was the awareness of hereditary risk, which count for 74.2%. While moving to the questionnaire item that got a lowest score was the reproductive factor, where they have indicated that they have 77.3%, whereby they have seen that knowledge of reproductive related factors such as early menstruation was very low, and have also called us to highlight that there is a need for a target education. Now moving to the respondent level of perception and attitude toward breast cancer screening, which was the research question number 2, we was able to see that they have also average based on the lesion that we was having, where the results have also indicated that there is an average level of perception and attitude toward the breast cancer screening, reflecting a moderate understanding and a general positive outlook toward early detection. While the most research question item that got a higher score was the recognition of importance of breast cancer screening, where most respondents have recognized the importance of screening, though misconception about non-scientific cause has also still persist. Now moving to the research question number 3, that was asking the level of screening practice for breast cancer. We was also able to see that the average were 44.71, where the findings have showed an average of level of screening practice, which also indicating a moderate participation in breast cancer screening among the respondents. And the one of the questionnaire item that got the highest score was the breast self-examination, where most women practice breast self-examination have indicated 86.4%. Now, the lowest questionnaire item, well, most of the respondents who were attending this study have very few had undergone a mammogram and also have also reflecting a limited access to awareness of formal diagnostic service. Now moving to the relationship between breast cancer awareness and social demographic research questions, the results have also revealed that there is a significant association between breast cancer awareness and also social demographic variables of religion, age, and ethnicity, while education level have shown no significant relationship. And this also indicates that culture and also demographic factor play a stronger role in shaping awareness than formal education. Therefore, the study have partially rejected the null hypothesis and also emphasized the need for culturally sensitive health. Now moving to the relationship between breast cancer screening and social demographic, the results have also shown a significant association between breast cancer screening practice and also social demographic characteristic, particularly the age, the ethnicity, education level, and the region. And age have also demonstrated the strong relationship with mammogram utilization, which also indicate as it is a key determinant of screening behavior, and consequently the null hypothesis was also rejected, which also highlight the need for age-specific and culture-tailored intervention to enhance breast cancer screening uptake. Now moving to the conclusion, women in Tamale metropolis have demonstrated a level Yes, moving to the conclusion, women in Tamale metropolis have demonstrated a moderate level of breast cancer awareness and screening practice, though engagement in formal and also screening method have remained low due to low cultural belief and health system barriers. And the study have also confirmed that social and also cultural factors, rather than education or socioeconomic status, significantly influence the awareness and also screening behaviors. Now moving to the recommendation that we have given to the study, it was being recommended to strengthen the community-based and also culture-tailored health education program in order to address those misconceptions and also to promote early detection, as we have seen in the result. And we have also additionally recommend to enhance accessibility to screening services and also to integrate what we call a breast health education into primary health care in order to improve the participation and outcome among women, as we have seen that most women who are located in Ghana, they don't participate in mammogram tests. So this is now the QR code that you can use also to access our full paper that we have conducted on Ghana related to breast cancer. Thank you all and God bless to everyone.
Yes, your slide is visible, doctor.
Okay, thank you. Good morning, everyone. It's a pleasure to be here today to discuss the emerging field of onco-wellness, a concept that bridges oncology and wellness through the use of nutraceutical supplements. So, nutraceuticals, it is a rich in bioactive compounds, play a significant role in supporting cancer therapies. They help reduce treatment side effects, boost immunity, and improve the overall quality of life for patients. So, through this presentation,
I will explore how these functional foods and supplements contribute not only to patient health, but also to a rapidly growing market in India and across the world. So in aim and scope, the key objectives of my presentation are: first, to discuss the potential of bioactive nutraceuticals in both cancer prevention and therapy. Second, to highlight the global and Indian market potential for onco-wellness products. And third, to promote awareness about the importance of nutraceuticals as safe and effective complementary care alongside conventional cancer treatments. So, nutraceuticals in chemotherapy. During chemotherapy, patients often face fatigue, loss of appetite, and oxidative stress. Nutraceuticals help by improving nutrient intake, supporting antioxidant defenses, and reducing inflammation. So, some products like ProSure, which is fortified with EPA, and Pro 360 Can Pro, a protein rich formula, are excellent examples. They improve lean body mass, appetite, and recovery, enhancing the overall effectiveness of chemotherapy while minimizing its side effects. So, natural nutraceutical products in cancer prevention. Nature provides us with the powerful compounds that fight diseases at the molecular level. For example, curcumin from turmeric has a strong anti-inflammatory and anti-cancer activity. Catechins from green tea help prevent tumor growth. Then omega-3 fatty acids from flax seeds help regulate immune responses and cell signaling. These natural compounds form the foundation of preventive oncology through diet and supplementation. Then, herbal based nutraceuticals in cancer prevention. As we know, India has a long tradition of herbal healing. Herbs like ashwagandha, tulsi, and giloy are known for their ability to strengthen immunity, detoxify the body, and reduce stress. Their adaptogenic properties make them highly valuable in maintaining wellness during and after the cancer therapies. Integrating these herbs into nutraceutical formulations bridges traditional wisdom with the modern healthcare. So, these are some examples of herbal nutraceutical products in India. So, several Indian products already demonstrate this integration. For example, Naturomol Immune Plus, made from tulsi, giloy, and amla, helps boost immunity during the chemotherapy. Then B Green Multivitamin, a plant-based formula improving vitality and metabolism. Then Naturomol De-stress includes ashwagandha, brahmi, and janamansi to reduce anxiety. Silver Age Immuno Enhance that contains spirulina and green tea extracts for antioxidant supports. Then ProSure EPA Drink, Pro 360 Can Pro, and Kiva Silver Plus. These also contribute to cancer care and recovery. Active ingredient based nutraceuticals. The efficacy of these products depend on active biocompounds such as omega-3 fatty acids, which reduces inflammation, lycopene and selenium, which acts as an antioxidant, EPA, which supports metabolism and muscle preservation. So these compounds enhance chemotherapy outcomes, improve cell repair, and prevent tumor proliferation. So here comes the global and Indian market demand for the nutraceuticals. So the global nutraceutical market has been expanding rapidly, as we can see in the graph. It grew from $455 billion in 2024 to nearly $498 billion in 2025, reflecting a strong annual growth rate of 9.5%. In India, healthcare investment increased by 13% in 2024-25, reaching approximately 90,958 crore. So this clearly shows that the Indian nutraceutical market is not only growing, but it becoming a major global contributor. These are the key drivers of nutraceutical market growth. So there are three major drivers I can say for this market. First is increasing health consciousness and the rise of preventive lifestyles. Second, a growing consumer preference for natural, plant-based, and immunity-boosting products. And third and finally, advancement in personalized nutrition and onco-wellness solutions tailored to individuals' needs. So these are certain challenges as there is a need for a strict quality control and nutri-vigilance in India, as some consumers with a tag of natural, they sometimes feel like it is a risk-free, but this is a consumer misconception about this. Then the requirement for more clinical validation of efficacy and safety. In conclusion, to summarize, nutraceuticals are emerging as a vital complementary therapies in both cancer prevention and management. They work hand in hand with conventional treatments to reduce toxicity and improve outcomes. India's strong base in herbal medicine and biotechnology provides a powerful advantage to become a leader in the onco-wellness market. Our next step involves more clinical validation, global partnerships, and integration of these products into a standard cancer care. So, future perspectives for this, looking ahead, our focus areas should include expanding clinical validation for the efficacy of nutraceuticals, then innovating new formulations with better bioavailability. Third, increasing public and medical awareness about onco-nutraceutical therapies. And finally, establishing a strong international safety and quality standards for the global recognition. Visual summaries, to summarize visually, nutraceutical science helps identify and extract bioactive compounds. So, onco-wellness uses them to support chemotherapy, boost immunity, and reduce toxicity. Market growth is driven by this awareness, innovation, and global demand. And the future vision is personalized, sustainable, and evidence based healthcare. These are some product reviews and clinical relevance which are found in the India. Then, future market scope and innovation. The future of this sector looks extremely promising. India's nutraceutical export potential is rising. Artificial intelligence and data-driven nutrition will personalize onco-wellness programs. Then eco-friendly formulations and nano-delivery system will improve absorption. Clinical trials and nutri-vigilance frameworks will build scientific credibility. And government as well as a private investment in health tech will strengthen India's position in the global market. So for the reference purpose, please go through this citation. Thank you all for your attention. It's truly exciting to see how science, tradition, and innovation come together in the field of onco-wellness. I look forward to your meaningful discussion on how we can advance the use of nutraceuticals for the better cancer.
Good morning. Thank you for your kind introduction, and I appreciate the opportunity to speak today and share my insight with such a distinguished audience. Okay. My presentation today, I will present the Wnt signaling associated protein, β-catenin and E-cad herin as the potential biomarker, immunohistochemical biomarker of the progression of adenoma and to colorectal carcinoma. I'm Dr. Hanan M Garalla, work as Associate Professor at the Department of Pathology, Faculty of Medicine in University of Benghazi. Okay, first let us navigating the complexity of colorectal cancer. The colorectal cancer is globally recognized as the third most frequently diagnosed malignancy and second leading cause of cancer-related mortality, and the adenocarcinoma account for the vast majority, over 90% of colorectal cancer. Okay, the colorectal cancer, now it's known as most preventable cancer, as it's typically arise from benign neoplasms such as tubular adenoma and serrated polyp, which progress slowly to malignancy, allowing for early detection and removal before the malignant transformation. And this is, we can deny the rule of colonoscopic removal of pre-malignant polyp, which is a highly protective strategy to prevent the colorectal carcinoma and will decrease and affect the overall mortality and patient outcome. Generally accepted, the colorectal cancer is heterogeneous disease which arising from complex interplay between the genetic, epigenomic instability and environmental exposure and age-related physiological changes contributing to the disease heterogeneity, which influence the disease progression and treatment response. Let us explain here that the cancer cell in colorectal cancer exhibits the phenotypic diversity, which make some cells display aggressive triad, which enhance the migratory and invasive capability. And this diversity in cancer cells within individual tumor may play the most important role in driving both drug resistance and tumor progression. Okay, with respect to the multi-step theory of carcinogenesis, it well documented that adenoma carcinoma sequence describe the process by which benign polyp develop into invasive cancer. Since it's correlate or it's connected between the size of adenoma, presence of dysplastic changes, and the architecture. So the villous adenoma larger than 2 centimeters has a greater chance than 50% chance of containing malignancy, different on other type of adenoma. So the adenoma carcinoma sequence here, this schematic illustration illustrates the conventional adenoma carcinoma sequence, and the classical stepwise model here described how the normal colonic epithelium progressively transform into invasive colorectal carcinoma through cumulative genetic phenotyping and alteration. The first stage, as see here, just thickened in the in epithelial lining, which represent the earliest hyperproliferation stage. Over time, and as the process progressed, the small adenomatous polyp, as we see, over time, when additional mutation accumulate, this drive the formation of large adenoma, show here as some prominent nodular growth attached to the mucosa. Within these large polyps, severe dysplasia can occur, and in this severe dysplasia, as we know, it's characterized by architecture distortion, and this stage reflecting an increased genomic instability, and these dysplastic cells undergo to pivotal event, which led to and detected histologically as irregular infiltrative mass, marking the transition from pre-malignant to malignant state. Finally, the tumor evolved into the advanced adenocarcinoma, occupying significant portion of clonic ileum. Okay, the intercellular signaling pathway network in maintaining the colonic epithelium, let's see how it's maintained from hemostasis, and their disruption may contribute to the tumor genesis. The establishment of normal intestinal architecture is essential for regulating the key cellular process such as proliferation, differentiation, and apoptosis. So the key pathways involved include Wnt signaling pathway, PI3 kinase and its downstream effector AKT, MAP kinase, and the transforming growth factor beta, which facilitate the communication between cells and ensure normal homeostasis. So any disruption of these signaling pathway can lead to uncontrolled cell growth and impaired intracellular interaction. For instance, we take this pathways as example when it's normally acting versus disrupted and inactive. So the transforming growth factor beta signaling typically function to inhibit the cell growth and promote apoptosis. If this signaling pathway disrupted, that means it will continue the cell's continued cellular growth and escape from the growth control mechanism, which is, as we know, it's hallmark of tumorigenesis. When the PI3 kinase activated due to mutation in PI3 kinase subunit, it further enhanced the cell survival and proliferation, which contributing to the malignant phenotype. MAP kinase signaling pathway, it's responsible for cellular growth and respond to growth factor. When a mutation in oncogenes such KRAS and BRAF can activate this pathway, leading to enhanced cell survival and leading to activation of downstream signaling cascades that enhance the proliferation and survival. The Wnt beta-catenin pathway is frequently activated in more than 90% of colorectal cancer, amplifying the pro-oncogenic signal and promote tumor growth. So definitely the interaction between these different pathways further amplifying the bronchogenic signal in colorectal cancer. As we see here, we insight into the molecular signaling pathway in colorectal cancer from initiation to carcinoma. As we see here, the starting point just show the normal intestinal healthy epithelium characterized by regulated cell proliferation and no histological lesion was detected. When we transition to the hyperproliferative stage, which is marked by activation and a mutation in ABC gene, which is a critical gene for regulating the cell growth. Also, additional factor involved in one signaling pathway, which led to promoting the cell proliferation and formation of apparent cryptid foci. The early activation of MAP kinase maybe also occur, particularly if there is a mutation in oncogene like KRAS, as we see. And this is driving from the hyperproliferative stage and further enhancing the cell growth. And this represents the benign stage of benign, but neoplastic growth that may develop further. The PI3 kinase, due to mutation in PI3 kinase subunit, induce apoptosis and leading to the survival of cells. And in addition to alteration in SMAD, also disruption in transforming growth factor beta signaling pathway, all of together allow for continuous cellular growth and escape from growth control. This combination of these changes result in development of carcinoma, and at this stage, the tumor suppressor gene B53 are common contributor in genomic instability and aggressive tumor behavior. If we look here to the interplay of E-cad, herin, and beta-catenin in Wnt signaling pathway in colorectal cancer and as a key players in Wnt-driven cellular changes. When Wnt signaling pathway off, as we see here in the schematic illustration of Wnt signaling pathway, active versus inactive. When Wnt signaling pathway off, this is a state E-cad herin engaged in cell adhesion, maintaining the tight junction between the epithelial cells. So in absence of Wnt ligand, the cytoplasmic beta-catenin is phosphorylated in a multi-protein destruction complex compromised, as we see, axon and GSK and ABC. Destruction complex is critical for intracellular assembly, responsible for the regulation of beta-catenin level in Wnt signaling pathway. When Wnt signaling pathway is inactive, this is led to an increase and continuously degraded by this complex and keeping its level low in the cytoplasm, and preventing its translocation to a nucleus, where it would activate gene transcription. And this is, we should keep the Wnt signaling pathway in this occasion inactive. When the Wnt signaling pathway is active and on, so this is, as we see here, the Wnt signaling pathway, when the Wnt ligand binding to Fresled receptor and low-density lipoprotein co-receptor. This is help in destruction. Complex are recruited to the cell membrane, and this is mean rendering the complex is inoperative. Which that mean? That mean in the cytoplasmic beta-catenin escape from degradation and translocated to the nucleus, where it's bind with the transcription factor and initiate target gene transcription, which put the process in colorectal cancer. So the combined effect of reduced E-cad herin and increase in nuclear beta-catenin contribute to the changes in cell behavior, such as increased cell migration, invasion, and potential oncogenic transformation. So based on this, some strategy for targeting one signaling pathway in colorectal carcinoma would be beneficial. So exploring the molecular alteration that direct progression of adenoma to colorectal cancer, it might help to identify clinical relevant biomarker of progression. And when signaling pathway disruption are linked to colorectal carcinogenesis. So various therapeutic options and agent include small molecules, antibodies, and peptides target this pathway. Based on this, the classification or categorization of Wnt signaling pathway inhibitor based on their specific target into generic inhibitor or inhibitor of Wnt receptor complex, inhibitor for beta-catenin destruction complex, and inhibitor target the nuclear transcription factor complex. Despite promising therapeutic development, there is no clinically effective, up to now, has approved for colorectal carcinoma treatment yet. Ongoing research focus on enhancing the efficacy of these inhibitors. Combination strategy, I think, combined the Wnt signaling pathway inhibitor with conventional chemotherapeutics may improve the treatment outcome, necessitating careful consideration of patient condition and available therapy by healthcare provider. So, based on this background, our study aimed to assess and compare the immunohistochemical expression level of E-cad and beta-catenin in a pre-malignant lesion, including tubular villus and tubulovillus adenoma, and to evaluate the association between their level of expression with the histopathological grade, stage, lymph node metastasis of colorectal cancer. So, this study aimed to clarify the potential role of E-cad and beta-catenin as biomarker for progression from adenoma and carcinoma. Okay, what we used in material and method, the tissue sample in the first part of retrospective study, we examined the surgically resected specimen in the study period between 21 to 23 were included, and the pathology report of 82 patients of a pre-malignant different type of adenoma, accounting for 48. And the colorectal adenocarcinoma, including the both subtype non-mucinous and mucinous adenocarcinoma, accounting 34, were collected, and the patient demographic and histopathological characteristics were obtained from both medical record and pathology reports. The processing procedure was done by choosing the representative paraffin-embedded tissue sample were selected for analysis, and the paraffin section were cut at 4 micron and stained with the routine hemotoxylin and eosine for routine histopathological examination, as well as for immunohistochemical staining. For immunohistochemical staining, the section of tissues were obtained, were incubated at room temperature using monoclonal mouse antibody, beta-catenin, and mouse monoclonal E-cad herin. For visualization, chromogene DABI was applied, and slides were analyzed by pathologists, and using Olympus microscope, representative field were selected for evaluation. Okay, what we depend on is in scoring method, the staining of beta-catenin and E-cad herin was scored according to the proportion and intensity category. This is proposed by Alert et al. Scoring system. As we see here in the table, Alert was based, the scoring based on intensity, giving the staining intensity given a score from 0 to 3. 0 stand for no staining, and 3 stand for strong staining intensity. and the percentage of positive cells detected in the field, and also divide the score between 0 to 3. 0 stand for 0%, there is no positive cells was detected in examined field, and 3 given for the when we find more than 50% positive cells in the examined field. So the staining was also evaluated and scored separately for membranous, cytoplasmic, and nuclear staining pattern. Staining score 0 and 1 considered low expression, while staining score 2 and 3 is considered high expression. The statistical analysis, the data were entry in Microsoft Excel, and we analyzed the all variable and summarized in frequency and proportion. The results were presented in table and graphs. The statistical significance using chi-square test was used, and p-value less than 0.05 was considered as statistically significant. Okay, our results here, as we see, the study included the patient age between 30 to 80 years with mean age of 52.9 years. The highest incidence of adenoma was observed between 30 to 40 age group, and peak incidence was noted for both type of adenocarcinoma at age group 61 to 70. This, or based on this result, this is highlight the importance of target screening and preventive strategy is needed with the age-specific approach in colorectal carcinoma surveillance to improve the early detection and treatment outcome. Our results regarding the gender, the most patients were male with 62.2%, and just 37.8% were female, giving the male to female ratio 0.6 into 1 for all studied sample. Okay. Now we try to correlate between the beta-catenin expression with various types of adenoma. As we see here, the beta-catenin expression was predominantly membranous localization, and the tubulovillous adenoma show higher beta-catenin expression compared with the tubular and villous adenoma, which correlated with their potential for malignant transformation. This data indicate that the tubulovillous adenoma that exhibited the higher beta-catenin expression compared with the other two types means the predisposed or the great risk of malignant transformation in this type of adenoma. Now we correlated the beta-catenin with our clinico-pathological characteristic of patient with colorectal carcinoma. This clinico-pathological characteristic represented as a grade, tumor stage, and lymph node metastasis. And we notice here the high expression of beta-catenin score was noted in advanced stage and even in low tumor of colorectal adenocarcinoma. And this correlation was found statistically significant. So we compared here the E-cad herin with various types of adenoma, and we found that E-cad herin highly expressed mainly in a tubular adenoma. As shown, this relation between E-cad herin expression and adenoma type is statistically significant. We tried to correlate the E-cad herin with the clinico-pathological characteristic in patient with colorectal cancer. The results indicate that E-cad herin expression decreased or declined, and this is corresponding increase in tumor grade stage and with the presence of lymph node metastasis. What that mean? That mean the E-cad herin, this suggests that E-cad herin play key role in maintaining the cell adhesion and maintaining the tissue architecture. So when the expression is dimensioned, this is mean the tumor lost their cohesive properties, leading to enhance the invasiveness of the tumor. Okay, here the tissue section was stained by H&E and immunohistochemistry. Here we examined the immunohistochemical expression of beta-catenin in adenoma versus colorectal cancer. From left to right, the first row stand for mucinous adenocarcinoma, then non-mucinous subtype, tubulovillous adenoma, tubular, and lastly villous adenoma. If we compared here the immunohistochemical expression in both either pre-malignant or malignant type of colorectal cancer, we see the beta-catenin expression show shift from membranous staining in adenoma to cytoplasmic, as we see here in the tubulovillous and villous adenoma. With maintaining the membranous staining in tubular adenoma. In adenocarcinoma, reflecting the activation of one signaling beta-catenin signaling pathway during the progression, because if we see the more nuclear localization of beta-catenin mainly in a mucinous type and non-mucinous adenocarcinoma. Here we compare the E-cad herin immunohistochemical expression in adenoma versus colorectal cancer subtypes. If we see here, the E-cad herin demonstrate preserved membranous expression in adenoma with cytoplasmic shift in tubulovillous and villous adenoma, but was fragmented membranous expression or lost in adenocarcinoma, and this is indicated reduced cell adhesion and increase the invasiveness mainly in the mucinous type. Okay. What our study discussion here, the mean age of participant, as we previously said, it's 52, with big incidence of colorectal cancer at the 61 to 70 year age group. And this is consistent with a prior study conducted in 2022. Male predominance was 62.2 was observed, similar finding by SK in 2021 and 2022 with other author. Most cases were diagnosed at advanced stage, classified as T3, reflecting the pattern observed by JOMA in 2022, while SK reported the predominance for T4. I think there is no much difference. Both of study, most of the cases diagnosed at advanced stage. The histological subgrouping of adenoma, tubular villus, and tubulovillus are linked with various varying malignancy potential, with our data showing that benign adenoma had high E-cad herin expression, while malignant adenocarcinoma exhibited low expression. And this is consistent with a finding from Choi 2021 and Milano Fischi, which is 2023, which noted the significant correlation between E-cad herin loss and tumor grade and stage, in contrast to JOMA, which found no such association. Also, our results showed the gradual intracellular translocation of beta-catenin from membranous to cytoplasmic to nuclear expression in a stepwise manner following the adenoma-carcinoma sequence, which in accordance with the finding with Wang et al. Have shown that mutation in beta-catenin can result in accumulation of a protein in the cytoplasm and cell nucleus, which result in increased transcriptional activity. In the present study, we showed that the membrane or cytoplasmic expression of E-cad herin has been linked with adenoma, reflecting progressive loss of cell adhesion. However, the adenocarcinoma E-cad herin expression was reduced, weakened, or lost, often with fragmented membranous staining and apparent cytoplasmic localization. These results align with the prior research showing the shift from membrane to cytoplasmic and mixed pattern of E-cad herin expression in colorectal carcinoma, and it's associated with poor differentiation and lymph node metastasis. Raj Kumar in 2022, also in contrast, Kova in 2012 found a strong E-cad herin membrane staining in both adenoma and carcinoma without shift in cellular localization. What we concluding and remark here and our perspective from the result of the present study, we can conclude that the type of histological differentiation of colorectal adenoma and adenocarcinoma are directly correlated with the intensity of expression of beta-catenin. The membranous cytoplasmic and the nuclear score show a linear progression with advancing stage of colorectal carcinoma, while E-cad herin expression show an inversely correlation with beta-catenin. The low level of E-cad herin expression are associated with poor prognosis and decreased survival in colorectal cancer patients. The study highlights the possible use of immunomarker like beta-catenin and E-cad herin could be used as useful prognostic marker for colorectal adenocarcinoma. So a long-term follow-up study will be necessary to identify the clinical value of beta-catenin and E-cad herin expression in colorectal adenoma and adenocarcinoma. But finally, I want to say that the incidence of colorectal cancer is varies and depend on the geographical place and ethnicity. All this affect dramatically on the cancer cell behavior and phenotyping plasticity and diversity.
Welcome to in third international webinar for cancer and breast cancer treatment. I would like to speak for designing and fabrication of antibody-tag nanolipid vesicles for targeting breast cancer cells. Coming to the point on this view, first we want to discuss what is the cancer. Cancer mainly is complicated biological disorder, biological in human body, biological disorder in the human body where the abnormal cell proliferation occurs in malignant cells. It is the uncontrolled and proliferation of cells which subsequent spread in the other organ and human body, means metastasize, we can say. The major therapeutic approach of cancer chemotherapy to deliver the correct amount, means exact amount of active pharmaceutical ingredient in the desired site, that is the malignant cells, and you can say neoplastic cell for longer durations of action. Next slide, you can see a chemical agent by inducing apoptosis. Previous slide, please. Previous slide, it induces apoptosis, and that is the mainly suicide of the malignant cells and arrest for neovascularization, that is angiogenesis, we can say. And mainly conventional chemotherapy worked by destroying abnormal proliferated cells due to its cytotoxic nature, and also it damages the normal healthy cells. And one common side effect for mainly cancer chemotherapy, that is, alopecia, hair loss, sometimes maybe nausea, or maybe sometimes vomiting, organ dysfunction, anemia, thrombocytomania, and myelosuppression and mucositis, etc. As per therapeutic drug monitoring, that is the strategies of modern chemotherapeutic preferentially destroying the malignant cells without having any harmful or toxic side effect on the normal healthy cells. Here, some passive targeting is this slide. We are coming to this point. Passive and active targeting has been implemented for recognition, diagnosis, and treatment for cancer, and widely accepted in the modern field of oncology. And our main approach, nanomedicine, for targeting some breast cancer cell, that is nanomedicine such as maybe nanoliposome or nanoparticle, polymer-based nanoparticle, combined with the genetic material administered to the target cells for cancer chemotherapy. The advancement of the novel nanomedicine to improve the therapeutic index of anti-cancer drug, or that is cytotoxic drug, also via modulation of pharmacokinetic parameters and tissue distribution to target sites. Due to nanosize range of the mainly cytotoxic drug loaded the nanodevices, mainly easily and malignant cells for, that is, leaky vasculature, and for their basement membrane and phenomena known as passive targeting. Here, this known as passive targeting. An active antibody or ligand molecule can be tagged with the some surface of the nano devices so that they recognize the uh, malignant cells via active targeting purpose, and so that medicament or active pharmaceutical ingredient release the site specific space for the program, or you can say predictable manner, so that they enhance the therapeutic efficacy of active pharmaceutical molecules and simultaneously reduce the side or toxic effect during cancer chemotherapy. Mainly here approach, next slide please. The novel strategy here, drug delivery technology applicable for conventional chemotherapy. We had tamoxifen citrate, anti-estrogen, that is non-steroidal derivative. We have chosen tribethyleninetin, that is also cytotoxic drug, mainly estrogen receptor positive breast cancer cells, which is mainly active. We are loaded in the tamoxifen citrate nanoliposome for targeting breast cancer cells. Here, the main schematic diagram, we have followed thin film hydration method, chloroform. Next slide, please. Here, that is the mainly antibody we have targeting. That is the fast rotary evaporator used for soil lecithin cholesterol in the thin film and direct sonication. We have reduced the size of the liposome so that nanosecond passive targeting in possible, and multileveler vesicles we centrifuge in the cold centrifuge were separated, and antibody were tagged, means were here used with the FITC level ER lipos antibody, human antibody tagged, so that they can recognize the anti cancer cells, or you can say neoplastic cells, for active targeting purpose. Here the schematic diagram for antibody conjugated nanolipid vesicles. Okay, then next slide please. Here, the some FECM mean field emission scanning microscope you have chosen for evaluation parameter for surface morphology of tamoxifen citrate nanoliposome. First phase, that is the tamoxifen citrate TNL1, that is formulation, and next one TNL phosphoethanol tagged for the linker molecule for so that antibody can be attached to the surface. The both picture images is homogeneously distributed, had smooth surface with nano-size dimension at the lyophilized state. And incorporation of phosphoethanolamide, that is the linker molecule, enhance the maybe size for liposome to attach the antibody for tagging purpose. Then next slide. The transmission electron, this is also antibody tag conjugated nanoliposome. We have previously told just a minute. That is the both surfaces are homogeneously distributed within the nano range 100 nanometer. As per slide you get it. This B group size is 23, and some liposome also 24.2 or 25.2 nanometer within the nano range, is homogeneously distributed, and both are smooth, very smooth surface. Next slide, please. The morphology here, the coming to this point, transmission electron microscopy. Here, the so both A, B, C, D poses, that is morphological image of transmission electron photograph, where nanoliposome can easily identified in the discrete vehicles, and black portion indicate that the drug or medicament that is the loaded the inside the vesicles for A to B, B and C or D also, and the light peripheral dimension indicate that the phospholipid bilayer and which contain cholesterol and visible as darker elongated spot. In the case of antibody conjugated morphological image, that is the D portion, you have some size is increased, but back portion indicate the drug is loaded in the inside the vesicles. And in case of antibody conjugation phosphoeth in the bilayer surface, the presence of antibody with phosphoethanolamide, predominantly vesicles, the number of darker, thicker, and polygonal particular matters, that is the respective represented B images, with phosphoethanolamide in the bilayer surface and the presence of antibody with PE. Then next slide, please. Cryo-TEM analysis. No, sorry, this is a particle size analysis, that is DLS technology, differential dynamic light scattering decay, that both are nanoliposomes show within the nano range within the 100 nanometer. You have seen the dynamic light particle size analysis. Next slide. This is the cryo-TEM analysis. Cryo-TEM means cryotransmission electron microscopy. This is the analyzing imaging was used for visualization of tamoxifen citrate loaded nanolipid vesicles with represented image shown of A, B, C, and D. That is the nanoliposome were found. That is some first one unilamellar spherical vesicles, and D portion shows bilamellar spherical vesicles having aqueous layer surrounded by the lipid bilayer as depicted A, B, C, and D also. However, few bilamellar liposomes detected, that is the D images, and dark membrane and some dark area in the core indicate that the possibility of presence of lipid-soluble drug in the membrane and some suspended drug particles in the core within the aqueous layer was within this entrapped inside the nanolipid vesicles. That the size of the liposome and the cryo-TEM depends smaller, someone 30 nanometer, and larger to maximum 150 nanometer vesicles. And we have selected larger and smaller liposome both for formulation. Here, lyophilized liposome suspended in water for cryo-TEM analysis and particle size measurement also. Next, next slide, please. There also cryo-TEM analysis for within the 100 nanometer range for antibody conjugated and some lipid vesicles with nanolipid conjugated. Here, because of aqueous nature, and green color arrow represent unilamellar vesicles fused with each other, and pink color, sky blue color arrow inside that the smaller unilamellar vesicles near about 50 nanometer within the diameter and near about 100 nanometer also. Next slide, please. Here, the confocal microscopy, both we have studied in vitro accumulation of entrapment of the cellular uptake study for conducting tamoxifen citrate loaded nanolipid vesicles. Here, without any conjugation, we have studied, that is the cell predominantly that confocal microscopy study performed to visualize the internalization and subsequent intracellular distribution of nanoliposomes. The cellular uptake and subcellular distribution of the nanoliposome, as seen using the confocal laser scanning microscopy, were predominantly concentration dependent, and FITC tagged liposomes were found to each reach cytoplasm successfully, but not in the nuclei also. Here, first A portion is a formulation at concentration 100 microgram per ml for 3-hour incubation we have studied, and next portion, that is the B image transmission tamoxifen citrate loaded with linker molecule phosphoethanol for formulation concentration 300 microgram per ml for 3-hour incubation for cellular uptake study. Please, next slide. Here we have studied in vitro cellular uptake study for tamoxifen citrate loaded nanoliposome conjugated with antibody, that is the here MCF7 cell. Previously also MCF7 cell we had without conjugation. Here also MCF7 cell, and comparative study also we have studies. We have shown that is the in vitro cellular uptake study in MCF7 cell. First one, formulation concentration 50 microgram per ml for 30 minutes and formulation concentration 100 microgram for 30 minutes. Because the active targeting, within the less time they can recognize the cancer cells. And breast cancer for different concentration we have studied. Here we have antibody FITC anti-human CD340, that is ERB. HR2 is estrogen receptor positive and Susan. Next slide, please. Here that different cancer, that is estrogen negative cancer, cell line MDMB 453 sense we have chosen for, that is the figure reveal that the tamoxifen citrate loaded nanolipid vesicles penetrate in the cell membrane. At higher concentration, more lipid vesicles were observed in the cell assessed by the confocal microscope images. It was found that the anti-cancer drug-loaded nanocarriers penetrate and distributed both in MCF7 cell, that is estrogen receptor positive cancer cell, as well as simultaneously MDA MBA 453 estrogen receptor negative cancer cells. This is the comparative study here. That is the different concentration, and you have seen in the slide 50 microgram per ml 1 hour, 100 microgram for 1 hour, and antibody conjugated nanolipid also in C and D for 15 microgram per ml for 2 hours, and simultaneously 100 microgram also. Both were internalized. That is our formulation and affected both estrogen receptor positive cancer cell, and that is MCC, and MDMB 453 cancer cell, breast cancer cells also. And next slide, please. This is the cytotoxicity, in vitro cytotoxicity as assay for negative control treated with only medium, and in these cells, that is the incubated with empty nanolipid liposome, that is the blank nanoliposome, that is a NL, it is denoted as last in paragraph, a blank nanoliposome, and did not show any cell death. Whereas the cell treated with drug-loaded nanolipid vesicles and free tamoxifen citrate exhibited cell death. A dose-dependent cytotoxicity was observed with tamoxifen citrate and tamoxifen citrate-loaded nanoliposomes. The cytotoxic effect of nanoliposomes were gradually increased with increased the tamoxifen citrate concentration itself. The toxicity, that is the tamoxifen citrate, was observed as the concentration rose from 6.5 yes, that is the x-axis, you have images shown, that is a 6.25 microgram per ml to 100 microgram per ml. The percentage of cellular viability of MCF7 cells treated with TNL1, that is the nanolip optimized formulation, and TNLP, that is the phosphoethanamine conjugated with tamoxifen node and nano formulation, both compared with of the cells treated in the free drug, that is tamoxifen citrate, to assess cytotoxic effect in the MCF7 cell in vitro. And concentration dependent reduction in the viability of MCF7 cell were observed after treatment with nanolipid formulation for 48 hours. In the toxic effect of TNL1, that is the TNLP, decrease in the cell viability from 95% to 12.22%, and from 96.51% to 13.49% respectively. Figure reveals that the cytotoxic effect for tamoxifen citrate against MCF7 cells was significantly higher than the drug loaded in the nanoliposomes. Next slide, please. And each bar diagram presented, that is the FACS analysis. Apoptosis assay by the FACS analysis was a fall forward to scatter, that is the FSC signal, and increase in the side scatter SSC, that is signal in the figure A and B, and some in the C and D dot plot. Point cell analysis, A fall in the forwarded scatter, that is the increase the side scatter signal indicate the cell death, and A for FACS analysis did not show dot plot from the point that the cell analysis showed that the basic morphological information of the cells, and flow cytometric study showed that the 95.9% of cells were viable, and 0.1% were showed in the basic morphological information of the cells. And flow cytometry studies showed that is the 95.9% cells were viable, for 0.1% were apoptotic, 0.4% were necrotic, and where no pre-apoptotic cells are present. And figure B revealed that the 90.9% were viable, since 0.6% were some more apoptotic cells, and 1.3% were pre-apoptotic, and 2% necrotic cells are present for in the diagram. Next slide, please. Please, next slide. The C, and D images, C indicate that the percentage of pre-apoptotic cells and the apoptotic cells treated with liposomal formulation were 1% and 1.8% respectively, while viable cells and necrotic cells were at 93% to 1.3%, and figure D showed that upon liposomal treatment, that is the trimethylphencyl loaded nanoliposome with phosphoethanolamines and antibody conjugated, that is the percentage of the pre-apoptotic cells and some apoptotics in the liposomal were present. And MCF several cell lines were visualized under flow cytometric analysis after staining of phosphodiesterine translocation with FITC annexin V in the combination with propydium iodide. And C shows that apoptotic and necrotic for red stain that expose free drug solution and drug-loaded liposomes. Next slide, you can. That is the comparison of cell viability of percentage between tamoxifen loaded nanolipid vesicles for phosphoethanolamine and antibody for the tamoxifen loaded nanoliposome for MCF 48-hour we have studied, that is bar diagram present, and percentage of cell viability statistical data for free drug here nanolipid vesicles. And for our experiment, we have concluded that the tamoxifen citrate nanolipid vesicles with linker molecule phospho and antibody conjugate nanoliposome with lyophilus reveal that the smooth surface in FECM images previously have told, that is the homogeneously distributed, and vesicles had an intact structure with no membrane leakage maintained by the vesicles. In the transmission electron microscopy, it's present, and cryotime analysis vesicle maintain the lamellarity, both have uniform and with nanored size. The results suggest that the tamoxifen loaded nanolipid vesicles may be preferential uptake and provide better therapeutic activity because of their smaller size, which leads to the enhanced permeability and retention effect, as you know, EPR effect, in the malignant or neoplastic cells, and simultaneously it is both effective in metastasized state, and so that they can antibody conjugated or tagged with nanolipid, they can recognize the neoplastic cells and prevent simultaneously angiogenesis. And both formulation, our antibody tag nanoliposome, both are effective in active as well as passive targeting, and our formulation showed that the predominantly cellular uptake in MCF7 cells, simultaneously it is also effective in MDMB 453, this is the estrogen receptor negative cancer cell line. The formulation developed active targeting for attaching specific antibody, that is the FITC anti-human CD340 for that is the HER liposome to the linker molecule present on the phospholipid bilayer surface, and antibody conjugate faster, better uptake in estrogen receptor positive MCF7 line compared to MD 453 estrogen receptor cancer cell line. And FACS analysis showed number of apoptotic and pre-apoptotic cells were found increased by using experimental formulation. That is this experimental result suggests that the nanolipid vesicle treatment with drug loaded more beneficial for the treatment of managed disease compared to free drug treatment in the breast cancer chemotherapy. Please next, any question? Next slide. Thank you. Any question you can.
Assalamu alaikum. Hello, everyone. I am pleasure to be here in Third International Conference Cancer and Breast Cancer Treatment in Dubai. My name is Mohammed Abdulhalim Al-Faqih. Graduated at 2025 from Faculty of Medicine, Misrata, Libya. This case report is study supported by Al-Razi University, Misrata, Libya, and this case also did it in Al-Hilal Abbad University, Misrata Hospital. Our case report today about the mesenchymal spindle cell tumor Now start with the abstract our case, background. Mesenchymal spindle cell tumor is very rare and have been reported to account less than 100% in hospital admission. A spindle cell tumor classified according to their origin into congenital neurogenesis, osseous or miscellaneous tumors. Our aim is a study. We are present the case of mesenchymal spindle cell tumor to raise awareness on this. Okay, the first we are talking about the abstract. The background, mesenchymal spindle cell tumor is very rare and have been reported to account less than 100% in hospital admissions. Spindle cell tumor is classified according to the origin into congenital neurogenesis, osseous or miscellaneous tumors. Our aim is to study. We are present a case of mesenchymal spindle cell tumor to raise awareness on their seldom found tumor. Case description. The patient's 40 years old male was admitted to our hospital, presented with recurrent huge left elbow swelling associated with reduced mobility in affected area, fatigability, malaise, and increase progressively. By examination, was fixed to the muscle, not tender, and stretched the skin. Complete investigation was with the normal CT scan showing recurrent left elbow sarcoma. And there is no any pulmonary or hepatic or osseous deposits. Wide local excision are done, elliptical incision with complete excision of the mass was done with the distal scarification of the radial nerve because it was involved inside the tumor. The mass sent to the histopathology and showing microscopically spindle cells in neoplasm, composition of fusiform spindle cells with the tibia having in the strict borders arranged haphazardly in short. Ill-defined vesicles with an infrequent mitosis. The patient, after the operation, received adjuvant chemotherapy and radiotherapy, 6-cycle chemotherapy and radiotherapy 8-cycle, and the following every 6 months, even to 2 years. And he has recurrence of the tumor after that. This is our pictures in UT, pre-operative and post-operative pictures. As you see here in this slide. Our discussions with the other papers, we reported the case of mesenchymal spindle cell tumor, which recurrence, a huge left elbow mass with limited margins were detected clinically and confirmed by CT imaging. To the best of our knowledge, soft tissue tumors usually occur in the limbus. Therefore, abdominal soft tissue tumors, especially retroperitoneal spindle cells, are uncommon. All patients diagnosed with sarcoma should also have a computed tomography scan of the chest at the time of diagnosis and in follow-up spindle cell sarcoma. Affect people of almost any age and sex. 2 separate studies. This is a study by Fink researchers and Smith. Median age was 57 years, all ages. Spindle cell carcinoma is a typical tumor. Spindle cell carcinoma is a typical tumor with a particular clinical behavior characterized by frequent local recurrence and a common distant metastasis. The spindle cell tumor is mainly composed of spindle cells by mature fat cells within the tumor and the consistency of spindle cells found on the mucus 6 matrix and coarse collagen fibrous bundle. Small spindle cells with a 3 single core nuclear extension for bipolar CD34 positive staining, often arranged along the collagen bundles, or a following umbrella distribution in fat cells. Usually these two kinds of cells are roughly same, mixed together, or all in open one place. Contains a lot of mast cells in the tumorous tissue is the unique point of the tumor. The tumor blood vessels in general, lipoma, spindle cells with polymorphic lipoma, have shown a nuclear aberration of chromosome 16q. Performance can occur in any organ or tissue. Morphology can be have shown a nuclear aberration of chromosome. Performance can occur in any organ or tissue. Morphology can be cancer or tumor, such as occurred in the epithelial cells, followed by cell carcinoma or squamous cell carcinoma spindle cells. Can also occur in mesenchymal tissue. Cell sarcoma is like a port-form spindle cells stromal sarcoma, complex shape performance, more similar to sarcoma, or shaped like a sarcoma with interstitial ingredient. Immune phenotype can be characterized by cancer. Spindle cell sarcoma are extremely rare, and there have been no reports. Standard oncology principle of enclosed resection of the tumor and involved organs remain a treatment of choice. We are present the case of mesenchymal spindle cell tumor. As we know, this is our aim to awareness on this seldom found tumor. The last slide, our conclusion. Soft tissue sarcoma is requiring the best expertise with appropriate treatment. Without appropriate treatment or resources, that may lead to consequences like metastasis or recurrence that causing significant problems to the patient. So regular follow-up after treatment are most important to avoid significant complications. The main surgeon was Prof. Dr. Muhammad Ahmed Al-Faqih, oncologist and founder of Misrata National Cancer Institute. And the second assistant in this case was Dr. Mu'taz Degweli, general surgeon in Hilal Abbad Misrata Hospital University, and me as a third surgeon. This is the references, and thank you for your attention and for any questions.
So thank you so much for providing this opportunity, scientific conferences. So before I begin, I want to acknowledge something very important. Most of the presentations of today I heard so far were more focused on the patient themselves, their biological biomarkers, their clinical outcomes, their treatment pathways, and disease-related variables. My work shifts the lens slightly, and instead of looking at only the patient, my research focuses on the psychological underpinnings of the caregivers of the cancer patients and people who stand beside the patient every single day. The cancer does not occur in the isolation, as we all know that, and it affects the entire system. And caregivers, especially in the countries like Pakistan, carry an immense emotional and physical responsibilities with themselves. Their rumination patterns and their changes in outlook directly influence the treatment adherence of the patient well-being, and overall family functioning. So the need for my study emerges from this gap, and while the medical and biological aspects of the cancer care are well documented, and mental health and the cognitive experiences of the caregivers remain under-researched, And that's why, despite being a critical on the part of the cancer care core system, with this perspective, I will now walk you through my research. So starting with my research, good afternoon, noon, everyone. My name is Ayman Nizam. I am not a doctor yet, but soon, inshallah. And I'm presenting my research titled Rumination and Outlook Changes Among Primary Caregivers of the Cancer Patient. This work was conducted under the supervision of Dr. Naeem Aslam at the National Institute of Psychology, Benghazi University, Islamabad, Pakistan. As a trainee now and a clinical psychologist and working in an the Skin Health Initiative and also in a research firm, Pakistan Institute of Living and Learning. These all experiences I have so far, my focus today is to highlight the psychological underpinnings of the caregivers that they go through while understanding like the processes and the demographics, especially for both the cancer patient, the cancer care, and the caregiver overall well-being. So my topic is rumination patterns and positive and negative changes among primary caregivers of cancer patient. So cancer is increasing at the unprecedented rate globally, and we saw like 20 million cases in 2022, and almost half of these were in Asia. By 2050, we expect this number to raise up to 35 million cases. And alongside this, there is an increase like an overall global population as it is increasing rapidly. And by 2050 also, there being that there will be 2.1 billion people will overall be above the age of 60. So as the aging of the population naturally remains in increase, the chronic illnesses and require a long-term support also. So in the countries like Pakistan and with the around 148,000 new cancer cases annually being reported, caregiving is largely and family duty. Like for more focusing, my focus is on the primary caregivers, the family members, that provide the emotional, physical, logistical support, often at the cost of their own well-being. So moving forward, research shows that caregivers can experience the level of distress equal to or even greater than the patient themselves. But interestingly, some also report positive psychological transformations, such as developing stronger relationships or deeper appreciation towards life, deeper appreciation towards other people, toward the overall the way they look at the world, because caregiving involves both the significant burden and alongside the potential growth, and it becomes crucial to explore what actually shapes these experiences of the caregivers. Particularly if I talk about my research, so that revolves around the rumination patterns, how the thinking shapes an overall journey and the changes in the outlook. Moving further, the theoretical background is considered. So in the psychological terms, as I'm a clinical psychology student and also a trainee psychologist. So the rumination is a key cognitive process that influences how individuals respond to the stressful or the traumatic events that are being present or they go through in their life. And here the diagnosis of the cancer itself is serving as an traumatic event. Intrusive rumination, the type of the rumination, which is the first type I catered, refers to unwanted or distressing thoughts that pop up in the mind automatically. While deliberate rumination, the other type of rumination, involves purposeful reflection, the thinking about the event, what actually happened with me, what actually is going around me. This is a deliberate one, and it is basically for serving the make the sense of it, what actually is going through. Similarly, the caregivers may experience the positive changes, such as reliance on or the new perspectives. Like this is a type of outlook, the first outlook, the positive changes. And there's another outlook, the negative changes, such as hopelessness or emotional exhaustion. Understanding these variables together in an amalgamation helps us to see how the caregivers mentally processes their caregiving experiences. The first research objective, overall objective for this research proposal was that to explore the effect of demographic determinants on the rumination patterns and outlook changes among primary caregivers of cancer patients. So particularly in my study, I put around the 14 demographics, and in these demographics there were multiple like cancer stage of the patient, therapy or surgery status, the therapy stage, the overall age, gender, monthly income, years of education, employment status, relationship with the patient, marital status, cancer type like carcinomas or others, or providing care like in months and hours spent in caregiver like overall per week. So my hypothesis for this very poster was to, after a diagnosis, positive and negative changes increases with the passage of time, and female scores higher on the intrusive rumination and negative changes as compared to male caregivers. Male scores high on the deliberate rumination and positive changes as compared to female caregivers. Caregivers who are having a social support scores high on the positive changes, and higher education is positively associated with the positive changes and negatively associated with the negative changes. Okay. So overall, the design I chose was a cross-sectional study, the correlational one, and sampling was non-probability purposive sampling. And the overall sample was retrieved from the oncology departments, like people sitting with their in the waiting areas in the overall oncology department waiting for their patient, and the data being extracted from the Rawalpindi and Islamabad, the twin cities of Pakistan. So overall, 131 caregivers were engaged, 63% of male and 37% of the female, age ranges from 18 to 57 overall. So the instruments that I used to retrieve the data was event-related rumination inventory, the Canetol 2011 author, and intrusive rumination having the 10 items, deliberate rumination having the 10 items, the 4-point Likert scale, intrusive rumination having the alpha reliability of 0.94, and deliberate rumination with the 0.88 reliability. And the changes in the Outlook questionnaire was used of the Joseph et al. The positive changes having the 11 items and negative changes having the 15 items, 6-point Likert scale with the alpha reliability of 0.83 and 0.90 respectively. So overall, ethical approval was obtained from the National Institute of Psychology, and the permissions were taken from the hospital management. This the hospitals that were engaged of the twin city, and voluntarily participation was agreed upon, and from the informed consents, the other like data analysis was used with the correlation, t-test, ANOVA. Further regression was also used, and that is being published already in the Pakistan Journal of Medical Research. For specifically this proposal for this conference, I choose to focus more on the demographic variables. So further, you can see the results that how the basically the scales, alpha reliability, skewness, and kurtosis were maintained, and the reliabilities with the other demographic variables, how they've been carried out. Please make that. And the results and discussion portion. Please move it like a little bit. No, I want that upper portion. Yes, thank you. Okay. So this is the overall graphical representation of my results, the 6 main demographic variables which I choose to present here. And we found the clear and meaningful demographic patterns that males reported more deliberate rumination and more positive changes, female reported more intrusive rumination and more negative changes. Caregivers with the social support experienced more positive changes, higher education correlated with the positive changes and the fewer negative changes. Caregiving for more than 12 months was associated with the deliberate rumination and meaning making. And cancer stage and the employment status also produce significant differences. So overall, these differences are based on of course, we know that there are changes in the male and female overall biology, and that is the main purpose that this is serving here, that difference of and also the amalgamation of the different demographics, how if the female is being employed and the male is being unemployed, how this is being carried out. So the further patterns and the further cross patterns can be explored in the researches, like in future researches. So overall, demographic context strongly shaped how the caregivers process these experiences. Please move to the interpretation portion. Conclusion. Okay, so these findings align with the broader trauma processing theories like post-trauma growth theory of Coughlin. So overall, if we Tedeschi and Coughlin PTG model, and these are basically that the process theories, that how these individual having the resources, whether emotional, financial, or social, may have more capacity to reflect and make the meaning and make the positive changes and growth. And those facing the multiple stressors such as financial hardships, lack of support, and overwhelming caregiving burdens are more likely to experience the intrusive thoughts and emotional distress. As a trainee clinical psychologist, this distinction is a very important aspect because it suggests very different intervention needs, that how basically the idiocentric approaches should be considered regarding the caregivers especially, and that can be amalgamated in the hospital settings, in the policy interventions. So overall, that aspect of the individualities and individual differences should be taken into account, and this research would be helpful for that aspect. So some caregivers need tools to regulate the distressing thoughts, and other may benefit from structured spaces to reflect and making meaning. So there's a differences in overall the aspect that how each individual should be taken and how each intervention should be separated from the other one. So what stand out is the complexity of the caregiving basically from this overall discussion I had. It is not purely detrimental or purely transformational. It is the both. Like if it has some downsides, so it also has some positive sides also. Our findings fit within the Pakistan's cultural dynamics, where the caregiving is considered a moral responsibility, and this creates a both emotional closeness and emotional burden. And rumination, therefore, becomes a key mechanism through which the caregivers either spiral into a distress or step into a personal growth. So it would help them. So practical application overall would be that these results highlight the several needs. Hospitals should integrate the caregiver support systems and programs, and also the psych education regarding the caregivers, how the caregivers go through the overall processes. Mental health professionals should assess the rumination styles when working with the caregivers, because it is being established that after the trauma, the person firstly goes through the intrusive rumination, and then the deliberate rumination part come, but that is the individual like a capability to go through the process to achieve that post-trauma growth. Some people got stuck on that intrusive part and they could not achieve that PTG or the post-trauma growth. So policymakers should recognize the caregiving as a public health concern and more focus to be put on that aspect. Intervention should strengthen the deliberate rumination and reduce the intrusive part, or people who are stuck on that part, we can help them. In short, improving the caregiver well-being will directly enhance the patient caregiver also. There are certain limitations of this study as this English language skills were being employed. So we will try, like in future researches, to make a more culturally specific language. For example, in Pakistan, more Urdu speakers are present. So that can be taken into account. Furthermore, this data being taken from the twin cities only, Pakistan in the Rawalpindi and Islamabad. So other cities can also be taken into account for the generalizability purpose, and self-report may come with the bias, of course. So cross-sectional design prevents that causal conclusions, so other aspects can be explored more widely and broadly if going through an longitudinal design, because that achieving a PTG or the post-trauma growth is a process. So we can see that how the fluctuations come in that process. So I would conclude that demographic factors play a significant role in shaping how caregivers mentally process the challenges of the cancer caregiving. Understanding these patterns is essential for designing culturally idiocentric sensitive interventions that can support both the caregivers. And when the caregivers are being supported, ultimately the result will be seen in the patient care and the patient's progress also. Thank you so much, everyone, for the listening to me. And at the end, I would like to acknowledge the National Institute of Psychology, the Dr. Naeem Aslam, for all the support he was giving to me at the time of the data collection, the oncology departments that were there. Thank you, everyone, for their attention. And I look forward if anyone has a question. Thank you.
Good afternoon, everyone. Good morning or good evening. I will be doing my presentation to us. It's more of an implementation best practice research that we were able to do in Kenya. Thank you. So I want to talk to us on bridging hope or bringing hope closer, where we are talking about a community-led breast cancer awareness and screening initiative that we were able to do with within Kenya through a mobile clinic. We call it Clinics on the Wheel, and we were able to do in the lake shores of Lake Victoria in Kenya. And this then definitely was able to ensure access of these given services. So this is an intervention that we did with a couple of my co-authors who are listed below. And I would like to indicate that in Kenya, cancer is still leading in terms of deaths. If you're looking at mortalities that are happening in Kenya, and you'll note that there are various preventive measures that the government of Kenya has been able to put in place to address these deaths that are resulting as a case of cancer. And so we've been able to have preventive measures like the HPV vaccinations, community awareness for early detections and treatment of both cervical and breast cancer. However, despite that, you note that breast cancer is still one of the leading causes that are leading in terms of deaths among mostly women in disadvantaged communities. And we know that we still have these difficulties because of inadequate screening rates, high mortality rates because of insufficient infrastructure, inadequate knowledge among community members, and especially women, and the capabilities to prevent and manage cancer in totality if we are not even looking at the breast cancer in itself. So in this particular initiative where we are looking at clinic on the wheels, we had 3 core objectives of ensuring that we are able to effectively detect, screen, and refer for given oncological services that are required. So the first objective was to improve community knowledge on breast cancer, looking at risk factors, signs, and importance of early detection. The second was to provide accessible breast cancer screening services through community outreaches, programs, and health facilities, and also strengthening referral pathways for timely diagnosis and treatment for women who had been screened and were positive. And so for us, in terms of our engagement, we were able to partner with the Ministry of Health in Kenya to implement clinic on the wheel. We understand that in Kenya, then there are those facilities that are static. However, women do not seek services in those given facilities, probably because of distance in terms of geography. The infrastructure to navigate and reach the facility is a challenge. Issues around cost, especially cost on reaching the facility, cost on accessing those given services, and as well the time or inadequate also providers in those given facilities. So we are talking about health system barriers that could be at the facility level. So this initiative that we started was to ensure that we reduce the burden of breast cancer, but at the same time ensuring that we are promoting awareness, we are encouraging early detection, and increasing access to affordable screening and referral services at the community level. So we are currently working to ensure that services are at the primary healthcare facilities. However, we know that challenges that encompass the primary healthcare facilities then need to be addressed so that we can effectively be able to reach those marginalized women and communities in the environs that we want to then reach. We were able to employ, in terms of our methodology, both quantitative and qualitative approaches, where we were looking at aspects of knowledge of the community members, the women themselves. We were looking at aspect of their screening uptake and how then this is documented, documentation aspect, especially on services provided and those that were then referred. So in terms of our beneficiaries, we were more keen on ensuring that we look at women of reproductive age, but more so we were focusing on women who were above 18 years in the selected geographies where the clinic on the wheel was doing their outreaches. We were also looking at other influencers that are able to create awareness at the community level. So here we were looking at community health promoters who are able to work closely with the clinical team, especially the nurses or the clinicians who are also in the outreach events, where they would focus on clinical breast examinations, emphasizing on aspect of self-breast examinations, but also ensuring that indeed the women who do actually go to the clinics for purposes of ensuring that whatever assessments they were doing was right and for confirmatory probably results. And so in terms of how the community sensitizations and campaigns were done, we were ensuring that in terms of messaging, we were also being culturally sensitive on creating breast cancer awareness. We know that on matters maternal health, or if you're looking at issues around sexual reproductive health, there's a lot of culturally appropriate messaging that is required so that the community indeed can feel that the services are then important, but we are culturally aligned, so we will not get backlash from them. We were also able to organize regular outreaches where within the mobile clinics we would work with facilities to ensure that then apart from breast cancer exam, referral, we would then offer also other integrated care and services. And so this was needful for us to do so with collaboration that we were doing with facilities, with the government, to ensure that then the selected sites were those sites that then community members were not able to reach facilities, community members were not able to actually get care because of inadequate staffing, or community members had no knowledge or where to access those given services. So we were able to work closely with the ministry to map and to ensure that then the selected regions or geographies would be able to serve the given communities. So in terms of access of those given breast cancer screening, which we did through outreaches and with the facilities that were linked with those outreach sites, we were able to have clinical examinations by the trained healthcare nurses. Besides that, we were also offering comprehensive counseling, but also ensuring that we had an immediate and functional referral mechanisms in place. And so the clinical team was still working within clinical standard operating procedures that the Ministry of Health had set for us in terms of screening, triaging, and also ensuring that we could be able to offer services that are required and refer. We noted that within the screening times, we would also experience those women that required other related services in terms of cancer, cervical cancer screening. We were also getting those that required probably STI management and those that also required contraceptive services. And so we needed to have that integrated so that we could provide that holistic care during those particular outreaches. We were also able to link two facilities that were close to those given geographies where we had pre-arranged referral pathways, especially to designated facilities that were able to do mammography or ultrasound or biopsy to clients that were then eligible for referral and further management. So we ensured that within those given parameters, we would be able to have enablers like use currently the health insurance funds that the ministry has set in. We were also using community health promoters to effect referrals that we were giving to the given facility, but at the same time ensuring that we were able to engage other stakeholders or influencers that were able to support those given clients that were referred. If we look at the results of how the outreaches we were able to conduct for a given period of 2024, we were able to conduct 4 outreaches in the lake shores of Homa Bay, where for us, within those outreaches, if you looked at it, we were able to reach a good number of teams where women were able to be screened for clinical breast cancer, and 12 were then referred for further management by oncologists. But we ensured that besides our outreaches, we were also incorporating other interventions, like we were also reaching out to community schools or schools within those given geographies, where we were offering, we call it the HPV vaccinations. We also learned that within those given communities, there were still low vaccination rates for the HPV. And so we were ensuring that the age categories of 10 to 14 could also be vaccinated. We were also working closely with the Ministry of Education, as much as Ministry of Health was core in this, in ensuring that we would also be giving health education to the students who are in schools, to the community members to upscale vaccination processes, but at the same time ensuring that also the women and the community members can be screened and be referred if then there was need. In my recommendation, I would simply say that with the few engagement with the clinic on the wheel, there is need to expand this particular model of clinic on the wheel to reach more underserved and rural areas, especially in Kenya, where women have limited access to breast cancer screening facilities, but then there is also need from those given communities. There is also need for us to have integration of other health services as we are doing outreaches, where we are looking at aspect of cervical cancer screening, we are looking at aspect of incorporating family planning, and also nutritional components, because as we were implementing the clinical breast cancer exam, we also need notice the increased community need to be able to provide other related services. because remember, we took those services once in a while to them. However, in terms of their need, that was much more expanded. And so there's also need for us to establish a clear, affordable, and efficient referral pathways for community and women, especially those that required advanced treatment for breast exams and for breast treatment that we were referring to those given government facilities. And as much there's need to invest in data, especially data for outreaches that are done, so that learnings and implementation based on the findings that we get from the community can be taken in for monitoring, screening uptakes, for ensuring that then in terms of referral completion, that can be made, and for ensuring that we can as well track treatment outcomes. And this particular intervention also need to be documented for evidence to inform policy advocacy, and also have additional or attract funding to upscale clinical on-the-wheel intervention at rural communities. In terms of replication, we noted that clinic on the wheel model is highly adaptable and can be replicated in either counties or regions with similar infrastructural challenges of geographies as similar as Kenya. And there is the need that this model then can provide that evidence-based integration in terms of mobile breast cancer screening, as much as we are looking at either country or county health plans, especially in resource-constrained settings like Kenya, where we are finding out challenges in terms of human resource, in terms of infrastructure to actually navigate and access services that communities or women need. And there's also need for us to note that with clinic on the wheels, we are able to leverage and reduce costs and distances that community members or families within the health system may want to access then those given services. And also that this particular initiative has demonstrated the power of partnership, both with the government, with healthcare providers, and communities that then require the given services in question. I would just like to conclude by indicating that Clinic on the Wheel, being a community approach, has shown strong promise in bridging gaps, especially in breast cancer awareness and screening. With adequate funding, training, and collaboration, we may be able to have a community-led model that is able to be replicated, especially across Kenya, but then can be able to save lives by ensuring that there is early detection and also early treatment of breast cancers that are identified at the community. So thank you very much, team, for listening.
Assalamu alaikum wa rahmatullahi wa barakatuh. Next slide, please. My talk will be about liquid biopsy markers for management of cancer. I'm Dr. Minha Swilam, Professor of Biochemistry and the head of High Throughput Molecular and Genetic Lab, Center of Excellence and Advanced Science, Biotechnology Research Institute, National Research Center from Egypt. Next slide, please. My talk will be with several points. My outlines will be on impact of liquid biopsy on cancer, microRNA biogenesis and function, microRNA detection, lab works of microRNA on oncology. Next slide, please. Cancer represents a significant global public health issue. The early detection of cancer and the development of personalized treatment plans are important factors in improving the outcomes and survival times of cancer patients. Currently, tissue biopsy remains the gold standard for tumor diagnosis. However, there are challenges related to difficulty in sample collection, potential harm to patients, and inability to continuously monitor changes and progression of the disease. Additionally, most tumors have an insidious onset, making accurate detection in the early stages via tissue pathology is challenging. Thus, to detect tumors and their features and monitor progression on the basis of analyzing biomarkers such as circulating tumor cells and circulating tumor DNA and also microRNA. Next, please. I will focus on my talk on microRNA, as this is our recent work in our lab. MicroRNAs are non-coding RNAs found only in eukaryotes. They have small size with an average length of 22 nucleotides. They are transcribed by RNA polymerase II from an independent genes. MicroRNAs play important regulatory roles in both human, animals, and plant cells. Next, please. MicroRNA biogenesis involves both nuclear and cytoplasmic processes. Pre-microRNAs are transcribed by RNA polymerase II and later processed by DORSHA to pre-microRNA. Extraportin 5 transfer these pre-microRNAs from nucleus to cytoplasm, where DICER processed them into mature microRNA. These mature microRNA can be selectively one strand for guide, which is called guide strand, incorporated with arginate protein of RNA-induced silencing complex and forms of myRISC, then binds to their complementary messenger RNA, promoting their degradation or translational inhibit. Other strand, which is called passenger strand, is supposed to be degraded normally in the cytoplasm. Next, please. This figure shows us how microRNA function in either normal tissue, microRNA as tumor suppressor gene, and microRNA as onco-microRNA. And this figure will be explained in brief. Next, please. Normally, a proper microRNA transcription, processing, and binding to complementary sequences on the target messenger RNA, which result in the repression of the target gene expression through a block in protein translation or altered messenger RNA stability. This is in case of the normal situation. While when microRNA act as a tumor suppressor gene, the reduction or the deletion of microRNA that functions as a tumor suppressor lead to tumor formation. And this is because a reduction or elimination of mature microRNA level can occur because of the defect at any stage of microRNA biogenesis, indicated by question marks arise in this figure, and ultimately lead to inappropriate expression of the microRNA target oncoprotein. Thus, the overall outcome might involve increased proliferation, invasiveness, or angiogenesis, decreased level of apoptosis, or undifferentiated or dedifferentiated tissue, ultimately leading to tumor formation. So this is the case of how microRNA act as a tumor suppressor gene in this case. Next, please. While microRNA act as an oncogene, this carried out by amplification or overexpression of the microRNA that has an oncogenic rule would also result in tumor formation. And in this situation, the increased amount of microRNA, which might be produced at inappropriate times or in the wrong tissue, would eliminate the expression of a microRNA target tumor suppressor gene and lead to cancer progression. So the increased level of these mature microRNA might occur because of the amplification of the microRNA gene, a constitutively active promoter, increased efficiency in microRNA processing, or increased stability of the microRNA. Next, please. Next, please. Okay. Currently, I would like to explore explain one of our study based on one of the most common type of cancer, which is breast cancer. Breast cancer is the second most prevalent cancer and the one of the leading cause of cancer-related death among females in Egypt and I think worldwide. According to Glucocan survey, 2.1 million newly diagnosed for female breast cancer. According to National Cancer Institute, breast cancer in Egypt account for about 38.8% of total malignancies among Egyptian females, and its incidence and mortality rates are among the highest in the Middle East. Late-stage diagnosis is common, and disease occurs at an earlier age than in Europe or North America. About 70% of breast cancer are sporadic, acquired during life, while 5 to 10% may be inheritable. Up to 90% of familial breast cancer patients are due to mutations in BRCA1 or BRCA2. Next, please. The risk assessment of breast cancer is based on clinical pathological features that primarily used for predicting metastasis at the tissue level. Some patients are difficult to treat due to disease heterogeneity and poor identification of metastatic disease. So early detection of breast cancer greatly improves the diagnosis and treatment for patients. This is critical for optimizing and management strategies to this disease. The common tumor markers like CEA and CA15-3 or other circulating protein molecules have been widely used as non-invasive biomarker for monitoring patients with metastasis, but with insufficient sensitivity to diagnose primary breast cancer. Thus, great necessity needed to develop novel biomarkers for breast cancer detection with high sensitivity and specificity. Next, please. So the aim of this study was to detect the clinical impact of some microRNAs like microRNA 21, 27, 155, 126, and 335 as a minimal non-invasive liquid biopsy markers for early diagnosis of breast cancer patients, then compare their expression with other benign breast lesions and healthy individuals. Also investigate their sensitivities and specificities versus the common used tumor markers like CA and CA15-3, assess their prognostic efficacy as compared to other clinical prognostic criteria. Next, please. Our materials and methods were recruited sample. The inclusion criteria were breast cancer group, which are newly diagnosed breast cancer females before starting any treatment strategies. Benign group, which are type of benign lesions, and healthy group, which were recruited from our lab staff or from control group, while exclusion criteria were patients with those undergo any mastectomy or lumpectomy or who received radio or chemotherapy, those with other types of malignancies or distant metastasis. The three groups were of age-matched Egyptian females. The number were primary breast cancer were about 200, for benign they were about 550, and control were about 40 individuals. Next, please. Expression level of microRNA and tumor markers, hormonal receptor status were carried out. All demographic and clinical data were recorded from their clinical sheets. Next, please. Statistical analysis were carried out using a statistical analysis program, and the fold change for investigated microRNA was calculated using the equation for 2 CT threshold. The association between clinical, pathological, and demographic factors with investigated microRNAs was determined. Receiver operating characteristic curve, which is abbreviated as ROC, curve was plotted between the investigated groups to detect the sensitivities and the specificities for the investigated microRNAs and their diagnostic efficacy. Disease-free survival was reported as the time from the first receiving neoadjuvant treatment strategy to the distal, regional, or local recurrence, second primary cancer, contralateral breast cancer. Overall survival was measured from the date of the first diagnosis to the date of last follow-up or death of patients. Both were analyzed using Kaplan-Meier statistical method and compared by log rank test. Next, please. This figure shows us the receiver operating characteristic curve for comparing the traditional tumor marker like CEA and CA15-3 with the investigated MER 21, 27, and 155. And as we can see, the highest area under the curve was recorded for microRNA 155, then followed by one CA 15.3, and CA with microRNA 21 and microRNA 27 were after them. Next, please. This also figure shows us the previous one, please. This figure shows us also the comparison between the traditional tumor markers and the other two investigated microRNAs, 126 and 335. And from this figure, we can conclude that the two microRNAs, which is microRNA 126, 335, were of highest area under the curve, which means that they can discriminate with an excellent manner between patients with malignant breast cancer or breast cancer patients and those with non-malignant individuals. Next, please. Next. The median and the positivity rate of investigated markers among the studied group. Now, as I have mentioned, we have three groups: breast cancer patients, patients with benign breast lesion, and healthy controls. By noticing that the median level, and using the receiver operating characteristic curve to establish the cutoff point for the other microRNAs or investigated microRNAs, we can see that the prediction for breast cancer was higher percentage among microRNA as compared to the traditional two tumor markers like CEA and CA15-3. As we can see that for example, microRNA 27, the expression of malignant breast cancer was 92%, while for CEA and CA15-3 was 49 and 52% respectively. The same for microRNA 335, it was 98% as compared to the traditional tumor markers. Next, please. The relation between the investigated microRNA and clinical pathological factors revealed significant correlation between microRNA 21 with late clinical stage, high grades, infiltrating duct carcinoma, and positive lymph node. The same results were recorded for microRNA 27, and for microRNA 155, it shows significant correlation with late clinical stage and high grade, and the same for 126 and 335, while for both tumor markers, CA and CA 115.3, they reported no significance with any of the clinical pathological factors. Next, please. To examine the detection of breast cancer, we compare the CEA, CA15-3 as two tumor markers which are established in the market as compared to the other investigated microRNAs. It has been reported that the sensitivity and the specificity for these markers, for these microRNA, was higher. Even as we can see from this table, that microRNA 126 has sensitivity of 100% as compared to that of CEA and CA15-3, which is within the 80%. And for the detection of early breast cancer, also the sensitivity for microRNAs, either microRNA 21, microRNA 27, 126, and so on, was higher than that for CA and CA15-3. The same observation was recorded for the detection of low-grade tumors, as the sensitivity and the specificity for the investigated microRNA was higher than the routine tumor markers used in the market. Next, please. To study the disease-free survival, patients with either high expression level of microRNA 21 and 155 or low expression of 126 reported worse disease-free survival from as shown in the figure below, while the overall survival significant difference was reported among microRNA 21 and microRNA 126 as increased microRNA 21 expression reported and decreased the expression of microRNA 126. Next, please. The decrease in the level of microRNA 335 is significantly related to worse both disease-free survival and overall survival. Next, please. So from these results, we can conclude that circulating microRNA expression level is a promising minimal invasive marker for diagnosis of breast cancer. Investigated microRNA were superior over the tumor markers for detection of early stage and low-grade breast cancer patients. Thus, assessment of microRNA in blood facilitates their role as a potential prognostic marker. Next, please. These studies were funded by Science, Technology, and Innovation Fund Authority, Basic Applied Research Support Grant, and these are the members of our lab. Next, please. Now I will present a brief about the lab work, which is mainly based on detection of these liquid biopsy markers among different types of cancers, and this was a study carried out to investigate the clinical significance of blood-based microRNA as diagnostic and prognostic nucleic acid markers in breast cancer. And this study was carried out upon detection of the expression level for microRNA 21, microRNA 126, and microRNA 155. Next, please. Also, this study was examining the clinical aspects of circulating microRNA 335 in breast cancer patients, which is reporting that the high sensitivity and specificity for this microRNA as compared to the other two routine tumor markers. Next, please. This study also was published in a journal of clinical biochemistry and reported that the potential diagnostic role of circulating microRNA in breast cancer and its implication on clinical pathological characters. And from this study, we have concluded that the investigated microRNA, like 222, 373, reported, and even microRNA 21 reported significant correlation with early stage and low-grade tumor, indicating that these microRNAs can be used as a diagnostic marker for those patients with high risk to develop breast cancer. Next, please. Also, this study was carried out on investigating the role of microRNA 155 and 181 as a prognostic biomarker for pediatric acute lymphocytic leukemia. As our lab work was mainly based on several studies on molecular markers for different types of cancer. We mainly worked on breast cancer, but other types of cancer are also being searched on. So we have used some of the microRNA to study their prognostic and diagnostic efficacy in other types of cancer, like lymphoblastic leukemia. And they have reported that not only they can diagnose type of cancer, but also they can categorize the different types of acute lymphoblastic leukemia. And this is research was published in Journal of Cellular Biochemistry. Next, please. Also, we have studied the role of microRNA as a liquid biopsy marker for prediction of glioblastoma, which is brain tumor grade 4. And these microRNA reported to be highly sensitive and highly markers for detection, the prognosis of these type of patients as one of the rare types of brain tumor. Next, please. Also, the prognostic utility of long non-coding RNAs as a molecular marker for glioblastoma has been investigated, and also this type of RNA were extracted from blood samples, and we have investigated two types of long non-coding RNA, which are 565 and 641, and they have reported their high sensitivity and specificity. Next, please. For using these microRNA as a molecular liquid biopsy markers, we have investigated other three types of microRNA in detection of colorectal cancer. Next, please. Also, another type of liquid biopsy marker was done rather than microRNA, which is detection of DNA methylation using liquid biopsy, using blood samples from patients to detect breast cancer. And this type of gene has reported to be significantly discriminate between benign, malignant, and controlled patients. Next, please. This is another study we have published recently in 2024. And also in this study, we have used two other types of microRNAs in detection of breast cancer. Next, please. This is one of the DNA methylation study used to differentiate or study the type of glioblastoma patients, and it has reported to be significance in differentiate the glioblastoma patients from the control, and also to act as a prognostic and predictor marker for this type of cancer. Next, please. This is our recent one published in Scientific Report Journal, which is carried out the expression of some circulating microRNA as a predictive biomarker for prognosis and treatment response in glioblastoma disease. Next, please. At the end, I hope this talk was with some benefits to the audience. This is my contact information. I'm looking forward to collaborate with the delighted audience. And at the end, next, please. At the end, I would like to thank the organizing committee of this webinar, and I was very happy to hear all of the talks, and they were all of valuable scientific points. Looking forward for collaboration. Thanks very much.
Hello everyone, I'm Dr. Stuti Trivedi. I'm a physician in India, and I'm really excited to give this presentation virtually. So I am giving a presentation today about a rare case that I came across last year of breast cancer recurrence nearly after 4 decades of its first appearance and its first treatment. And I would like to give shout out to my preceptor or my senior doctor during this encounter. It's Dr. Rene Rubin. So thank you to her. Now sharing a little bit history about the patient. So in 2024, last year, in a hematology and oncology clinic in Philadelphia, USA, I came across an 89-year-old woman from Ashkenazi Jewish descent who presented for a very abnormal looking scar and very itchy scar on her right side of chest. And she did have past medical history in way back in 1983 of a positive stage 3 infiltrating duct carcinoma, and it was treated, and which I will tell you about later on. And in a few years after that, again it was recurred, and it was again declared to be in remission. Now, coming back to 2024, she went to a dermatologist, and because it was a very abnormal looking scar with discoloration, and it was very itchy for her. So, given her past medical history, the dermatologist decided to take a punch biopsy and uh, go in depth of this lesion, and which showed adenocarcinoma of breast origin. And after this, the patient was sent to us in an hematology and oncology clinic. So, so we did have some of the medical records from 1983 when she was first diagnosed with breast cancer, and those records showed that her breast cancer was receptor positive, which is estrogen progesterone receptor positive. um, it was first treated with right lumpectomy, and that followed by prophylactic bilateral mastectomy. And also there was a combination chemotherapy was given. A chemotherapy regimen was given with cyclophosphamide, methotrexate, fluorouracil, vincristine, and prednisone, and that lasted for around 9 months to 10 months. And then she reportedly took tamoxifen for 5 years. And a year after that, she was in remission, and she underwent bilateral breast reconstruction, and she underwent prophylactic abdominal hysterectomy with bilateral salpingo-oophorectomy. And after that, she was in a remission for a few years. And when she had again recurrence of cancer in her right chest wall, and which was managed with radiation, and after a few months she was declared to be in remission. And so from around 1985 to 2024, she was doing pretty good. However, between this timeline, she was found to be osteoporotic, and then again she was treated with relaxaphane, which was approximately lasted for 5 years. Now, coming to the presentation that I came across in 2024, so we did, of course, thoroughly investigated her entire lesion and her entire body, and some of the positive some of the interesting negative findings are like this. Her PET scan was normal, so there was no any signs of metastasis. Her receptor came back positive for estrogen, strongly for estrogen receptor, and more than 30% strong intensity with progesterone receptor. Her study came back negative for HER2 expression, and we checked her gene mutation, and she was negative for BRCA. So ultimately, she was diagnosed with BRCA negative, ERPR receptor positive, recurrent localized adenocarcinoma. And if we look back at the timeline, she was first diagnosed in 1980, around 1980, and now it's 2024. So it has been more than 4 decades after her primary treatment for breast cancer. So because it's such a huge timeline and huge gap, I think it's important to discuss some of the major achievement and major milestone that we have gained over the course of a few decades, particularly in breast cancer. So the first treatment was radical mastectomy. It was to remove the entire tissue, and around mid 20th century, with the identification of radiotherapy, we started using post-surgical radiotherapy, and we started seeing some of the advancements in that. And around mid 1970s, we identified some of the chemotherapeutic agents, and they started using combining surgical and chemotherapy treatment. Of course, now we have so many options. And then the shift from radical mastectomy to lumpectomy was observed around late 1900s, when we started using all the combination therapy, and we started observing that we can preserve the tissue and still be in remission. And two of the major things that were observed, one was in 1896 by Thomas Beatson. He observed that there is a possible correlation with oophorectomy and breast cancer, so that later on proved very beneficial, especially for BRCA genes, for patients with BRCA gene mutations. In 1977, tamoxifen was approved by the FDA when they observed that during menstruation with cyclical estrogens, it has some effect on estrogen receptor positive breast cancer. Now, so if I think about this particular case, I think what makes it very interesting is that it kind of raises this question that why there was a recurrence after 41 years. I mean, what really helped to keep the cancer cells dormant? And is there anything useful that we can take from this case and apply it somewhere? So we came across two major things that were unconventional, I would say. The first is the prophylactic abdominal hysterectomy and bilateral salpinge oophorectomy. We believe, and there are of course evidence, that the procedure of course eliminates the cyclical hormonal fluctuations, and this could have a profound impact, especially in estrogen and progesterone positive breast cancer, positive receptor breast cancer. And so earlier, when she, around late 1900s, she was of course not BRCA positive, but she received treatment similar to as if she has BRCA mutation in her body. So historically, these procedures were common because we didn't have we didn't have any advanced management options, but of course not anymore. And the second unconventional thing that we could find is the patient, in the course of her journey, was diagnosed with osteoporosis. So she completed or finished her treatment with tamoxifen for breast cancer, and for her osteoporosis she was put on raloxifene for nearly 5 years after completing tamoxifen, and that the treatment with raloxifene lasted for 5 to 6 years. Of course, I mean, the current data does not support this practice, but we speculate that continuing raloxifene after tamoxifen may have maintained cancer cell dormancy for such an extended period of time. And it could be possible that without raloxifene, the recurrence might have occurred much sooner. And so ultimately, I think ultimately I would say that our case, some of the incidents may offer long-term preventive benefits, and it could really help remove some of the financial burdens that we observed with newer therapies of all these radiotherapies, chemotherapies, and advanced management options. And it could be really beneficial for resource-limited healthcare setups, and with women who have a high risk of recurrence, with especially the triple negative breast cancer, or some of the hormone receptor positive negative combination breast cancer, inflammatory breast cancer, the size of tumor based on the size and location of tumor. So if the woman is at high risk of breast cancer recurrence, and she cannot afford some of the advanced management options, so in our opinion, this one of the two, or this two unconventional management might be proved beneficial. And of course, there is we do require further research and data necessary to validate the strategies. But this is something, some unique characteristic or some unique management options that we observed in this case, and in our opinion, that may have helped keep the cancer cell in dormant. But we need further research and advanced data to validate these strategies. So that was the last slide, and I thank all of you to listening to me and being here. So thank you so much.